In endocrine practice, few scenarios are more frustrating. A type 2 diabetes patient achieves their strict LDL-C target, yet still suffers a sudden myocardial infarction. Addressing this exact diagnostic blind spot, where physiological testing shows a patient is safe while their biology remains in active disease, is the core mandate of the newly published 2026 ACC AHA Dyslipidemia Guidelines. This document shows the 2026 ACC AHA Guideline on the Management of Dyslipidemia. As explicitly stated in the AIM section, this clinical practice guideline entirely retires and replaces the legacy 2018 algorithms for blood cholesterol management. The central pivot in these new guidelines is a move away from measuring total cholesterol mass. Instead, the standard of care now requires quantifying the absolute count of atherogenic particles circulating in the bloodstream. This distinction is critical for populations with cardiovascular kidney metabolic, or CKM, syndrome. KKM syndrome is a systemic disorder where metabolic risk factors and renal dysfunction compound to accelerate cardiovascular disease. In these patients, insulin resistance alters lipid metabolism, causing traditional LDL-C mass measurements to frequently underestimate the true atherosclerotic risk. Relying solely on LDL-C mass in modern endocrine practice leaves metabolically vulnerable patients exposed to invisible, residual cardiovascular risk. The physiological mechanism driving this diagnostic failure is the high prevalence of cholesterol-depleted LDL particles in insulin-resistant patients. Because the particles hold less cholesterol per unit, the overall mass appears low, even when the sheer number of particles is dangerously high. Consider two hypothetical blood vessels. Both yield identical LDL-C mass measurements on a standard lipid panel. However, they have vastly different absolute particle counts. Vessel A carries its cholesterol in a few large spheres, while vessel B carries the exact same mass distributed across dozens of tiny, dense spheres. While the total cholesterol mass appears at goal in both scenarios, the high volume of small, dense particles in vessel B drives a significantly higher atherogenic burden. Their size and sheer quantity make them highly efficient at penetrating the endothelial wall of the blood vessel and initiating plaque formation. This dangerous phenomenon is known as discordance. It requires physicians to adopt a new set of biomarkers capable of directly measuring the true pathogenic threat rather than relying on aggregate mass. Physiological mass does not equal physiological damage. To prevent cardiovascular events, clinicians must count the weapons, not just weigh them. To establish a true baseline risk, the 2026 guidelines elevate two critical new biomarkers. The first is lipoprotein A, commonly referred to as Lp(a). Lip(a) is an independent, genetically determined driver of atherosclerotic cardiovascular disease. Because its circulating levels are dictated almost entirely by genetics, it remains highly stable throughout a patient's life and is largely unaffected by lifestyle changes or standard statin therapy. This guideline outlines a new Class 1 recommendation mandating universal Lp(a) screening at least once in all adults. As detailed in the recommendation-specific text, the high-risk threshold is 125 nanomoles per liter, or 50 milligrams per deciliter, correlating to a 1.4-fold increased cardiovascular risk. When an elevated Lp(a) result is detected, the immediate clinical response is the aggressive, early control of all other modifiable cardiovascular risk factors to compensate for this permanent genetic burden. For patients with clinical ASCVD who are not reaching their lipid goals on statins, a high Lp(a) measurement is now a formal trigger to escalate therapy by adding a PCSK9 monoclonal antibody. PCSK9 monoclonal antibodies are injectable biological medications that inhibit a specific protein, allowing the liver to rapidly clear atherogenic particles from the blood. This highly targeted biological intervention physically clears the stubborn pathogenic markers that standard statin therapies simply leave behind. Missing an elevated Lp(a) means missing a permanent genetic risk multiplier. Legacy lipid panels were entirely blind to it. The second critical biomarker is used not just for establishing baseline risk, but for dynamic therapeutic tracking. This critical marker is apolipoprotein B, or ApoB. The biological value of ApoB lies in its structural elegance. There is exactly one ApoB protein molecule wrapped around every single atherogenic particle, whether it is an LDL, an Lp(a), or a VLDL. VLDL, or very low-density lipoprotein, is an additional lipid particle that primarily carries triglycerides. Because of this strict 1-to-1 ratio, measuring ApoB provides a direct absolute count of the total atherogenic particle burden circulating in the blood. This section of the guidelines highlights the new Class 2A recommendation for ApoB testing. It specifies that measuring ApoB is highly reasonable to guide therapeutic intensification for adults on lipid-lowering therapy who have CKM syndrome, diabetes, or elevated triglycerides. The epidemiological proof is definitive. In cases of discordance, where LDL-C mass indicates low risk but ApoB count indicates high risk, ApoB is mathematically and consistently proven to be the superior predictor of future cardiovascular events. ApoB serves as the ultimate diagnostic tiebreaker in metabolic disease. It reveals the true residual risk hidden behind an artificially normal LDL-C mass. Translating this pathophysiology into daily application requires architecting an updated clinical workflow for the endocrinology practice. This chart details the first step. The classic Friedewald equation for estimating LDL-C must be retired. The Friedewald equation is an older mathematical formula prone to severe inaccuracies in patients with metabolic disease. Instead, the guidelines mandate using the Martin, Hopkins, or Sampson NIH equations, adjusting for triglyceride interference, reducing baseline discordance. This initial baseline assessment must also include the one-time LPA test to establish the patient's genetic risk floor. Step 2 requires initiating maximally tolerated statin therapy. This is based on traditional ASCVD risk calculators and aims to drive down the bulk of circulating lipid mass. Step 3 is the critical discordance check. Once the patient hits their initial LDL-C goal, the physician must not stop. If the patient has diabetes or triglycerides over 150 milligrams per deciliter, the clinician must order an ApoB panel. Declaring victory at an LDL-C goal in a diabetic patient is an incomplete protocol. Passing the discordance check is mandatory for definitive medical clearance. The 2026 guidelines provide highly specific ApoB treatment targets that dictate exactly when to intensify therapy. This chart displays the 2026 lipoprotein goals matrix, mapping out precise thresholds for various patient profiles. For primary prevention in diabetic patients without additional ASCVD risk factors, the target is clear: drive ApoB strictly below 90 milligrams per deciliter. For diabetic patients with additional ASCVD risk factors, the target intensifies. The ApoB count must be driven below 70. And for the most vulnerable population, patients with established clinical ASCVD at very high risk, the ultimate, most aggressive target is driving ApoB below 55. If ApoB remains above these thresholds despite maximally tolerated statins, the guidelines explicitly mandate intensifying therapy. This requires adding non-statin agents like ezetimibe, bempedoic acid, PCSK9 monoclonal antibodies, or inclisiran to directly lower the particle count. Precision lipidology now demands quantifying the exact particle burden. By integrating ApoB and LPA into standard practice, endocrinologists can identify, track, and neutralize the hidden residual risk in their most vulnerable patients.